Wait, before you scroll or waste another dollar on hyped up skincare, ask yourself this. How long have you been fighting acne, dark spots, and scars with zero real results? It's time for facts, not myths. Subscribe to science. Trust what's proven. As a board-certified dermatologist like Dr. Sandra Lee, I want to make one thing clear. Acne is a medical condition, not a cosmetic flaw, not a hygiene issue, and definitely not something you grow out of just because someone told you that you would. Every statement I'm about to make is grounded in dermatologic research and clinical practice. Acne vulgaris develops because of 4 scientifically established mechanisms. First, increased sebum, oil production, stimulated by androgens. Second, abnormal keratinization, meaning skin cells inside the pore shed improperly and stick together. Third, proliferation of Cutibacterium acnes bacteria within the clogged follicle. Fourth, inflammation. These 4 factors are documented in dermatology literature for decades. Any treatment that works must target at least one of these pathways. If it doesn't, it's marketing, not medicine. Let's start with oil production. During puberty and often continuing into adulthood, androgen hormones enlarge sebaceous glands and increase sebum output. This has been demonstrated in multiple endocrine and dermatologic studies. Sebum itself is not bad. It protects and moisturizes the skin. But when excess sebum combines with sticky keratinocytes, a microcomedone forms. The microcomedone is the invisible precursor to every acne lesion. Weeks before you see a pimple, it has already started forming beneath the skin. This is why topical retinoids are considered first-line therapy in evidence-based acne guidelines worldwide. Retinoids such as adapalene, tretinoin, and tazarotene normalize desquamation, meaning they regulate how skin cells shed inside the follicle. They prevent microcomedone formation. Numerous randomized controlled trials show that retinoids reduce both inflammatory and non-inflammatory lesions. They also stimulate collagen production over time and improve post-inflammatory hyperpigmentation. This is not anecdotal. It is documented in peer-reviewed dermatology journals and supported by the American Academy of Dermatology guidelines. Retinoids must be used correctly. Clinical studies show irritation is common in the first 2 to 4 weeks. This does not mean the treatment is failing. It reflects increased cellular turnover. A pea-sized amount for the entire face is sufficient. Using more increases irritation without increasing efficacy. Gradual introduction significantly improves adherence and outcomes. That recommendation is based on patient tolerability data. Now let's talk about bacteria. Cutibacterium acnes is part of normal skin flora. It becomes pathogenic when trapped in an oxygen-poor, clogged pore, where it proliferates and triggers an inflammatory immune response. This inflammatory cascade is responsible for red, swollen, painful lesions. Benzoyl peroxide works because it releases free radical oxygen species that destroy bacterial cell walls. Importantly, no bacterial resistance to benzoyl peroxide has been documented in decades of use. That fact alone makes it one of the most reliable over-the-counter treatments available. Concentration matters. Clinical trials demonstrate that 2.5% benzoyl peroxide is as effective as 10% but causes less irritation. Higher strength does not equal better results. It equals higher irritation risk. That is science, not opinion. Topical antibiotics such as clindamycin reduce inflammation and bacterial counts. However, monotherapy with antibiotics leads to resistance. This is proven microbiologically. Therefore, dermatology guidelines explicitly recommend combining topical antibiotics with benzoyl peroxide to reduce resistance risk. This is standard of care. Salicylic acid is a beta-hydroxy acid that is lipophilic, meaning it dissolves in oil. Because it penetrates into the pore lining, it helps exfoliate from within. Studies confirm it reduces comedonal acne, though it is generally less potent than prescription retinoids. Overuse, however, compromises the stratum corneum barrier, increasing transepidermal water loss. Barrier damage leads to irritation, and irritation increases inflammation. Inflammation worsens acne, so more is not better. Barrier health is critical. Research shows that disrupted skin barriers increase inflammatory cytokine production. Harsh scrubs, alcohol-based toners, and aggressive exfoliation increase irritation markers in the skin. Gentle cleansers with neutral or slightly acidic pH maintain barrier integrity. Washing twice daily is sufficient. There is no scientific evidence that excessive washing improves acne outcomes. Hormonal acne is real and well documented. Adult female acne often localizes along the lower face and jawline due to androgen receptor density in those regions. Oral contraceptives reduce circulating androgens and increase sex hormone-binding globulin, thereby decreasing free testosterone levels. Multiple FDA-approved oral contraceptives have demonstrated significant acne reduction in controlled trials. Spironolactone blocks androgen receptors and reduces sebum production. Studies show improvement rates exceeding 50 to 75% in appropriately selected female patients. These are not beauty hacks. They are endocrine-modulating therapies. For severe nodular cystic acne, oral isotretinoin remains the only medication that targets all 4 pathogenic mechanisms simultaneously. It dramatically reduces sebaceous gland size and sebum production by up to 90%, normalizes keratinization, decreases C. acnes colonization, and reduces inflammation. Long-term remission rates are high. Decades of follow-up data support its efficacy. It requires monitoring due to teratogenicity and potential side effects, but under medical supervision, it is one of the most transformative treatments in dermatology. Now let's discuss dark spots. Post-inflammatory hyperpigmentation occurs when inflammatory mediators stimulate melanocytes to overproduce melanin. This is especially common in darker skin types due to higher baseline melanocyte activity. UV exposure increases melanogenesis, which is why sunscreen is medically essential. Broad-spectrum SPF 30 or higher reduces pigmentation worsening. Studies clearly demonstrate that daily sunscreen accelerates fading of hyperpigmentation compared to no sunscreen use. Azelaic acid is supported by clinical trials showing reduction in both inflammatory lesions and hyperpigmentation. It inhibits tyrosinase, a key enzyme in melanin production. It also has antimicrobial and anti-inflammatory effects. This dual action makes it especially valuable for patients dealing with both acne and pigment. Vitamin C, specifically L-ascorbic acid in stabilized formulations, reduces oxidative stress and interferes with melanin production. Hydroquinone remains one of the most potent topical depigmenting agents, though it should be used under supervision due to risk of ochronosis with prolonged misuse. Evidence supports its short-term effectiveness. Scars are different from dark spots. Acne scars form due to collagen destruction during intense inflammation. Histologic studies confirm dermal matrix damage in atrophic scars. Topicals cannot rebuild deep structural collagen loss. Procedures like microneedling induce controlled dermal injury to stimulate collagen synthesis via wound healing pathways. Fractional laser resurfacing creates microthermal zones that remodel collagen. Subcision mechanically releases fibrotic tethering in rolling scars. These interventions are based on wound healing physiology, not guesswork. Diet plays a supportive role. High glycemic index foods increase insulin and insulin-like growth factor 1, IGF-1, both of which stimulate sebaceous gland activity and keratinocyte proliferation. Controlled dietary studies show that low glycemic diets reduce acne lesion counts compared to high glycemic diets. Evidence regarding dairy, particularly skim milk, suggests a possible association, potentially due to bioactive molecules affecting hormonal pathways. The relationship is not universal, but is supported by epidemiologic data. Stress increases cortisol, which promotes inflammation and may increase sebum production. While stress alone does not cause acne, studies show correlation between stress levels and acne severity. This supports the role of holistic management alongside medical treatment. Consistency remains the most important factor. Clinical improvement typically requires at least 6 to 8 weeks because acne lesions begin forming weeks before they surface. Skin turnover cycles average 28 days in younger individuals and longer in adults. Stopping treatment early prevents accurate assessment of efficacy. A simplified, evidence-based routine includes a gentle cleanser twice daily, benzoyl peroxide in the morning for inflammatory lesions, a topical retinoid at night for prevention, non-comedogenic moisturizer to maintain barrier integrity, and daily sunscreen. Adjustments are made depending on severity and skin type. This approach aligns with dermatologic treatment guidelines. Picking and squeezing acne increases risk of post-inflammatory hyperpigmentation and scarring due to deeper dermal injury. Studies confirm mechanical trauma exacerbates inflammation. Hydrocolloid patches reduce picking behavior and maintain a moist, healing environment, which may support faster resolution. Acne can persist well into adulthood. Epidemiologic data show significant prevalence in women in their 20s, 30s, and 40s. It is not solely a teenage condition. If over-the-counter treatments fail after consistent use for 12 weeks, evidence supports escalation to prescription therapy. Acne is highly treatable when approached systematically. The key is targeting pathophysiology, protecting the skin barrier, using clinically validated ingredients, and allowing time for results. The truth is simple. Acne responds to science. Retinoids prevent clogged pores. Benzoyl peroxide kills bacteria without resistance. Hormonal therapies reduce androgen-driven oil. Isotretinoin shrinks sebaceous glands. Sunscreen prevents pigment worsening. Procedures rebuild collagen in scars. These are documented facts supported by decades of research and clinical outcomes. Clear skin is not about trends. It is about understanding the biology beneath the surface and treating it intelligently, consistently, and medically.